Welcome back to Diabetic Foot Files. I'm your host, Dr. G, and today we're going to talk about another thing, another silent threat. So, patient walks into the clinic with a diabetic foot ulcer. You're doing everything right. You're offloading, you're debriding, you're protecting. Place them in a cam boot. The wound starts improving, and then 2 weeks later, the patient's in the ER. The shortness of breath, SOB, tachycardia, oxygen stopping. What do you think it is? What do you think the diagnosis is? A pulmonary embolism, not from neglect, not from infection, but from immobility. We usually associate it when it comes to a fracture. Let's say a patient was in a motorcycle accident, got a fracture, had put in a cam boot, and then a few days later, maybe they start feeling severe leg pain, things like that. We associate, but a lot of people don't think about it when how cam boots can contribute to venous stasis when we're immobilizing patients for our diabetic foot ulcers. So today we're going to talk about that, the pathophysiology behind clot formation, the progression from DVT to a PE, risk stratification, prevention strategies, and clinical red flags that we cannot afford to miss. So what is a CAM boot? Again, I love me a CAM boot. Controlled ankle motion, that's it's an acronym that is designed to offload pressure, redistribute joint movement, and promote healing. But here's the problem. It also reduces ankle dorsiflexion and plantar flexion. It limits your calf muscle contraction. It alters your gait mechanics and it encourages a sedentary behavior. So this is like the perfect storm for a DVD, and this isn't fear mongering, and that's also why I love me a night splint. Okay, to fix that calf muscle and to do ankle range of motion exercises and calf pump exercise is really good. But why would you use a cam boot? Okay, because cam boots are not our enemy. They're actually one of the most valuable tools in a limb salvage situation. So our primary indications for cam boot in a diabetic foot patient to offload those plantar pressures, especially forefoot ulcers, reduces peak plantar pressures up to 50 to 70% in some studies, protection from shear forces, so prevents repetitive trauma, stabilization of the soft tissue, so promotes granulation and epithelialization, and it's a great alternative to a total contact cast, which is like gold standard. So cam boot versus total contact cast. Total contact cast, like I said, is gold standard. But why do we often choose a cam boot instead? Because a total contact cast is non-removable, requires expertise. You can't nobody, not just anybody can apply it. And it has a higher risk of iatrogenic wounds. Cam boots are removable, adjustable, safer in less controlled environments, but the removability is a double-edged sword. So patients remove it, or worse, they leave them on and stop moving entirely. So, what do the guidelines say? The International Working Group on Diabetic Foot consistently state a non-removable knee-high device has the best healing outcome. Removable devices like Cambu has lower adherence, which causes slower healing. But here's what's not emphasized enough: the immobilization risk. So most studies focus on the healing rates, the pressure reduction, but few emphasize the thromboembolic complications. So everybody in med school, y'all know Burko's triad, the foundation of a clot formation. So every clot begins with three key factors. Venous stasis, so the blood isn't moving, so that causes a clot risk to skyrocket. Cam boots, your calf pump isn't pumping as much, okay, because it's immobilized, and that lowers your venous return. Then the endothelial injury. So diabetics often have microvascular damage and chronic inflammation. And then third is the hypercoagulability, often seen in diabetics or people who have infection, people who have surgery, and immobilization. So this is the triad that is the gateway to a thrombosis: venous stasis, endothelial injury, and hypercoagulability. So, what is the pathophysiology from boot to clot to possible death? Okay. So, and this is not fear mongering, like I said, but education. So, patient placed in a cambu, calf muscle becomes inactive. The blood pools in the deep veins, especially lung, the posterior tibial and the popliteal veins, clot forms, aka a DVT. Clot dislodges, travels through the inferior vena cava, the right heart, and into the pulmonary arteries, lodges into the lungs, causing a pulmonary embolism. I mean, pulmonary embolism is also one of the high risk after surgery, okay? And everybody should know that. So, what happens during a pulmonary embolism? Blood flows to the lung is blocked, and then the oxygen exchange decreases, the right heart strain increases, and this can lead to hypoxia, cardiac collapse, and sudden death. So, what are the signs that we should never ignore, especially when it comes to DVT? So, unilateral leg swelling, calf pain, warmth, redness. So, what are the signs of PE? Sudden shortness of breath, chest pain, tachycardia, or syncope, which is a late sign, a bad late sign. And thank God for, like I said, I love my residency. They were very well versed in this and were able to see the signs very quickly. And I know my attendings saved a lot of lives because they are so intelligent and I appreciate them so much. So, why are diabetic patients at high risk? So, diabetics, they're at high risk of this because it's stacked with a lot of risk stratifications like peripheral arterial disease, peripheral vascular disease, like I said, neuropathy, which causes less movement, right? Chronic inflammation, infection, which could cause a prothrombotic state, obesity, which is a common comorbidity with diabetes, and recent surgery or recent debridement. And add a cam boot, you amplify the risk. So the hidden danger, healing, the patient's healing well, but they're not moving. So this is where we can get blindsided. We're focused on the wound size decreasing, infection resolving, tissue granulating, but the patient still is sitting more, walking less, losing calf pump function, and the wound heals, but the patient still becomes a clot risk. So, what should we be doing as clinicians, especially with our diabetic patient or any other patient, especially if you put them in a CAMBU? Risk stratification, risk stratify every patient. So, what tools do we use? The Wells score. The Wells score is for DVT slash PE risk, and the Caprini score, and that's for surgical patients. So the Wells score is for DVT versus P. And what does that actually tell you? It's a pretest probability tool. It doesn't diagnose DVT or P. It tells you how suspicious you should be before imaging. So the Wells score uses a point system. So the Wells score for DVT is if the patient has active cancer, +1. If there is paralysis, paresis, or immobilization, aka CAMBU, +1. If the patient's been bedridden for more than 3 days, +1, or recent surgery. If there's localized tenderness or deep veins, +1. If there's entire leg swollen, +1. There's calf swelling greater than 3 centimeters versus the other leg, the contralateral leg, +1. If there's pitting edema, +1. If there is collateral superficial veins, +1. If there's a history of a previous DVT, +1. And alternative diagnosis just as likely is a 2. So interpretation is if it's 3 points or more, equal to 3 points or more, there's a high probability. 1 to 2, moderate. 0 or less, low. So in our diabetic patients, offloading plus infection plus inflammation, they're often at moderate to high risk even before imaging. So what about the Wells score for a pulmonary embolism? So it's a point system as well. So clinical signs of DVT is +3. PE, most likely a diagnosis, like just saying from your clinical judgment, is a +3. Heart rate greater than 100, a +1.5. Immobilization slash surgery is a +1.5. Previous history of DVT or PE, +1.5. Hemo, this, forgive me, +1, and cancer, +1. So interpretation is when you calculate it all together, if it's 6 or higher, high risk of PE. 2 to 6, moderate risk. Less than 2 is low risk. So if your patient is in a CAM boot and suddenly has tachycardia, shortness of breath, and chest pain, treat it as pulmonary embolism until proven otherwise. I mean, if they're having this is sepsis, I mean, you need to differentiate. Okay. So the Caprini score, the surgical hospital risk. Okay, this is used more for post-op and inpatient risk stratification. So the risk categories are 0 to 1 is low, 2 is moderate, 3 to 4 is high, and equal to or greater than 5 is high risk. And so for diabetic patients, they're often hit the 5 or higher very easily because of age, infection, immobility, and possible surgery, aka debridement or amputation. And these patients should always have prophylaxis unless it's contraindicated, in my opinion. Okay, that's my opinion. So, what does research say about DVT or PE risk? So, let's bring in the vascular literature. So, studies that show lower limb immobilization do show the DVT incident ranges from 4% to 40%, depending on the risk profile. Even in low risk patients, immobilization increases clot risk significantly. And the condition is often studied that they study is venous thromboembolism. So, what are the key findings? Immobilization reduces venous velocity, especially along the popliteal vein. Ankle movement is critical. So loss of dorsiflexion decreases venous return. So that's why it's so good to still do ankle range of motion exercises, even if it's out of the bed, off the bed, and calf pump exercises. Okay. Calf muscle inactivity is a major driver of stasis. Okay. That's why I love me a nice blend. Okay. And even short-term immobilization, like 1 to 2 weeks, increases the risk. So, what about the cam boots specifically? So, research is still emerging, but early data suggests that cam boots restrict the ankle range of motion. That's the whole point of it. And to mimic partial immobilization. And the patient often compensates by walking less and sitting more. So the risk becomes more behavioral as well as biomechanical, and you encourage mobility. You should even if the patient's in a boot, like wiggling your toes, seated calf contractions, even short walks if it's safe. Okay, and then compression therapy when appropriate. So graduated compression stockings, and avoid this in patients who have severe arterial disease. Okay, I think that's a no brainer. Okay. And then pharmacological prophylaxis. So in high risk patients, they usually prescribe enoxaparin or apixaban. Always coordinate this with the primary care doctor or vascular. That's why I always refer my patients to vascular, get a full workup. Usually, a lot of my patients do end up on anticoagulations, okay, even if it's something simple as aspirin, okay? But also educate your patients. It's very critical to educate them. If you feel shortness of breath, that is not normal. That is an emergency. So what do we order if we suspect a DVT or PE? Okay. So suspected DVT, we order a venous duplex ultrasound. For a suspected pulmonary embolism, gold standard board question, CT pulmonary angiography. Screening, D-dimer. That's the easy one too. An easy, quick one, D-dimer. Draw D-dimer. Okay? And so when it comes to that, ooh, I totally forgot how to, well, don't worry about it. Okay? So we went through the Caprini score and everything like that. So let's do a quick case study segment. So 58-year-old diabetic male, plantar ulcer, placed in CAN boot, no coagulation, limited mobility. 10 days later, complains of tight calf pain, dismissed as boot irritation. 3 days later, sudden shortness of breath. Okay, massive pulmonary embolism. So, and see the double-edged sword, like I said, the CAN boot is offloading, great for, but we also think of patients who have neuropathy. They cannot feel as well. It's not just in their lower extremity; it's in their whole entire body. They can't feel as well. Their protective sensation is compromised. Okay. So a lot of people are able to save their life from a DVT because they're able to feel this pain in their calf or have this shortness of breath. But usually starts with the calf pain and the swelling. Okay. And then you compare the contralaterals and you want to rule out a DVT. Okay. And then there's certain risk factors that also increases your risk of having a pulmonary embolism, like taking birth control. Okay. So keep those things in mind. So offloading without mobility planning is incomplete. So you have to encourage them to still do range of motion exercises. That's why also physical therapy is a good option as well, okay? That's why you always have to get vascular consultation for the patient, assessment. Healing a wound does not mean that the patient is safe. The calf muscle is our second heart, in my opinion. So shouldn't be turning off that heart, okay? And every immobilized patient is a clot risk until proven otherwise. And like I said, think of the calf pump as a hydraulic system. That's why I keep on saying I love me a nice splint. Muscle contraction pushes the blood forward, upward, and then the calves prevent the black flow. And Cambu causes pump failure, and that result is blood stagnation, which can cause a clot formation. So next time when we're thinking about using a Cambu afterthought, is this patient mobile enough? Do they need anticoagulation therapy? Did I educate my patient on PE symptoms? Because the danger is rare. It isn't just about a wound, and that's a good thing to know, okay? So we save limbs every day, but we're also trying to save lives. That's the whole point of trying to increase the quality care of your life is to help save your life as well. But sometimes, things that protect the foot can threaten the lungs. So that's the whole point of being able to be well-rounded. And yeah, this is Diabetic Foot Files. I'm Dr. G, and take care of your feet because they take care of you.